Hello everyone, welcome back to our channel. I'm Dr. Ashmita. Today I want to discuss in detail about Hodgkin lymphoma. So this name Hodgkin lymphoma, it was given and it is named after a British physician and pathologist named Dr. Thomas Hodgkin. Thomas Hodgkin first described the Hodgkin lymphoma. So this Hodgkin lymphoma, it is a distinct malignant lymphoma. That means malignant means it is cancer of lymphoma means lymphoid cells. Lymphoid cells include T cells, B cells or the natural killer cells present in the lymphoid tissues. The lymphoid tissues include most commonly it is the lymph node and also spleen, liver, bone marrow, and in the intestinal wall, like your GIT, contains Peyer's patches. Peyer's patches are nothing but the lymphoid aggregates in the intestinal wall. So these are the tissues that contain the lymphoid tissue. So the lymphoid tissue contains T cells, B cells, and natural killer cells. The neoplastic transformation of either of these cells is named lymphoma. It usually forms a solid tumors. Unlike leukemia, leukemia is presence of neoplastic cells in the circulation, in the flowing blood, whereas lymphoma is a solid tumor. It is solid tumor present in some organ. It has settled in an organ. And the lymphoma, it arises from B cells. It arises from the B cells. Hodgkin lymphoma arises from the B cells present in the germinal center or the post-germinal center of lymphoid follicle. I'll explain this germinal center and post-germinal center with a diagram in the next slide. And this Hodgkin lymphoma, it is characterized by presence of a diagnostic cell. So the presence of this characteristic cell is essential for diagnosing Hodgkin's lymphoma. This cell is called a Reed-Sternberg cell. It is called a Reed-Sternberg cell or simply called an RS cell. So presence of this RS cell is very essential for making a diagnosis of Hodgkin lymphoma. And along with this diagnostic cell, the background contains other inflammatory cells like lymphocytes, plasma cells, eosinophils, macrophages, neutrophils, and fibroblasts. These are the various other cells present in the background which make up the inflammatory background. So this image, it is the histopathology image of Hodgkin lymphoma. Here you can visualize this characteristic. This is the characteristic large cell. It is a lymphoid cell, it is a B cell, and it has two nuclei. There are two nuclei which are mirror images of each other. So it is binucleate, it is a binucleate cell, and inside the nucleus, this is the eosinophilic inclusion. So, binucleation with eosinophilic inclusion is the characteristic of this RS cell and it appears like an owl's eye. It appears like an owl's eye. The owl's eye appearance of this RS cell is the diagnostic hallmark of an Hodgkin lymphoma. And the background, it contains mixed inflammatory cell. All these are the lymphocytes. Maximum this slide shows you the lymphocytes. Here and there are plasma cells with eccentric nucleus that is located peripherally to one end. Also, there are like eosinophils with orangeophilic, like orangish cytoplasm. So, presence of lymphocytes, here the plasma cell, here the eosinophils. This makes up the inflammatory background, mixed inflammatory cells. Coming to the origin, the RS cells arise from, as we have discussed, from the B cells of germinal center or the post-germinal center of the lymphoid tissue. For example, you consider a lymphoid organ like a lymph node. For example, you consider this as a lymph node. The lymph node made up of this inner medulla. This inner portion will be the medulla. The peripheral portion will be the cortex. The peripheral portion is the cortex. The cortex contains many round structures called follicles. These are the follicles. These are the lymphoid follicles. What do they contain? Each follicle, when I take out this one, each follicle, The outer zone, this is the marginal zone, little in between layer, this is the mantle zone, this is the mantle, and the innermost, this is the germinal center. So the neoplastic transformation of B cells are present here. These B cells or the post-germinal just above it, the germinal center or the post-germinal B cells, they undergo transformation of cancer, neoplastic transformation. This cancerous B cells, these are called the Reed-Sternberg cells. This is about the origin of Hodgkin lymphoma. And the markers of normal B cells are, this is regarding the markers of normal B cells. Normal B cells contain CD markers, CD 19 to 23. That means 19, 20, 21, 22, 23 are present, CD40 is present, CD10 is present, also CD79A is also present. These are the few normal markers. So, of special importance is of the CD21 because it gives entry the Epstein-Barr virus responsible for the pathogenesis of Hodgkin lymphoma in cases of infective causes. This Epstein-Barr virus, it gains entry into this B cell via the CD21 marker. Therefore, the CD21 is of special importance in our PPT. So, and in case of neoplastic B cells, like the RS cells, the normal B cell markers are lost. So normal B cell markers are lost. Why? For example, this is a normal B cell. The neoplastic B cell do not contain these markers. The normal B cell markers are lost. Why? Because the immune system, the host immune system cannot identify this cancerous cell. The immune system cannot identify the malignant B cells. The immune system can recognize the normal B cell. If it has to become like cancer, it has to escape the host immune response. Therefore, to escape the host immune system, to escape from the checkpoint, it loses all the normal B cell markers. Therefore, it escapes the immune checkpoint. That is why there are loss of normal B cell markers in an RS cell. Coming to the epidemiology, that means the distribution of Hodgkin lymphoma across the age and gender. Firstly, it constitutes 10% of all lymphomas. 10% of all lymphomas are constituted by Hodgkin's lymphoma. The rest 90% it is constituted by non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma of either B or T cells. So the minority 10% is constituted by Hodgkin's lymphoma, and this Hodgkin's lymphoma, it shows you a bimodal age distribution. That means the first peak occurs in a young adults, like around 15 to 35 years. It is between 15 to 35 years, and the second peak is seen in elderly above 55 years. So it has this bimodal age distribution, and Hodgkin's lymphoma has a male predominance, most commonly occurs in males, and there's an exception to this gender, nodular sclerosis. In nodular sclerosis variant of Hodgkin's lymphoma, which is most common in females or it is most common in women. Except nodular sclerosis, all other Hodgkin's lymphoma, they are more common in males. And coming to the etiology, that is the causative factors, it is divided into infectious causes, genetic causes, immune causes, and the lifestyle or the environment causes. There are four causes. It is segregated into four reasons. First being the infections, Epstein-Barr virus and HIV. These two are most commonly associated with causation of Hodgkin lymphoma, and these both are most commonly associated with certain variants called mixed cellularity and lymphocyte depleted variants of Hodgkin's lymphoma. These both show association with HIV and Epstein-Barr virus. Coming to the genetical factors, Hodgkin's lymphoma has a tendency to run in families especially associated with HLAs like HLA class 2, that is DR and DRDP. They are most commonly associated with Hodgkin's lymphoma, and certain genetic alterations like the clonal immunoglobulin gene rearrangement. First, Second, mutation of NF-kappa B pathway. Third, JAK2 amplification. I would like to explain the immunoglobulin gene rearrangement. For example, in case you consider a normal B cell, the function of B cell is to produce the immunoglobulins, that is heavy chain and light chain. Ultimately, B cells form plasma cells. From plasma cells, you get the antibodies, that is the immunoglobulins with heavy and light chains. So, the normal B cell, it needs to have this immunoglobulin gene in its DNA, this immunoglobulin gene. This gene has various DNA segments, like it is a V segment, that is a variable segment, D segment called diversity segment, and J segment called join or joint segment. These are the three segments present in a normal B cell. Like this gene contains, one of the gene may contain this combination V, D, J. Other may contain D, J, V. Other may contain J, V, D. So these are like few recombinations. The normal gene contains variety of gene sequences. There are variety of gene sequences is present in cases of normal B cell gene. This is called polyclonal. Polyclonality means it is normal finding in B cell. Whereas what happens in this malignancy or the cancer or the tumor, this polyclonality is absent. It becomes monoclonal. That means if the neoplastic B cell it takes up VDJ gene rearrangement, all the neoplastic B cells of that lymphoid tissue origin, it contains all the gene segments contain the same VDJ. All this contain VDJ. That is, it becomes monoclonal. Monoclonal. So this monoclonal pattern, it confirms there is presence of RSL, that is the neoplastic B cell. This is the meaning of clonal immunoglobulin gene rearrangement. It rearranges in such a way that it produces monoclonality. And mutation of NF-kappa B, this will study in detail in the pathogenesis. The NF-kappa B is a normal nuclear transcription factor. It is a normal transcription factor present in the cytoplasm in inactive state. Whenever the signal has been received by the cell, this gets activated, goes to the nucleus, and cause B cell proliferation. So mutation of NF-kappa B will cause uncontrolled proliferation of B cells. And JAK2 amplification will also cause uncontrolled proliferation of B cells that we'll study in pathogenesis. Coming to the third factor, that is immune dysregulation. So it is associated with patients of immunosuppressed who are immunosuppressed, like the transplant recipients who are put on immunosuppressants. This is one example of Hodgkin's lymphoma associations. Other associations are lifestyle, like for example, high socioeconomic group or the highly developed countries. These light groups, they are less exposed to the common infections, so they have a delayed immune response to common infections. Therefore, for any viral infections, they are more prone for cancerous progression. So these are the few etiological factors, that is the infections, Epstein-Barr, HIV, genetic factors like HLA class 2 like DR, alterations like clonal immunoglobulin gene rearrangement, that is monoclonality will prove the RSL, mutation of NF-kappa B and JAK2 amplifications, immune dysregulation like immunosuppression, lifestyle like socioeconomic or elite groups, developed countries, socioeconomic groups, they are more prone for development of Hodgkin's lymphoma. Now, let us study in detail about the pathogenesis. And firstly, I want to emphasize on the role of Epstein-Barr virus in the causation of Hodgkin's lymphoma. So, this Epstein-Barr virus, it will gain entry into this B cell via this surface receptor called CD21. The normal B cell has the CD21 receptor on its surface. It gives access to the Epstein-Barr virus to enter inside this cell and enter inside this B cell. You consider this large circle as a B lymphocyte and this center as the nucleus of the B cell. And this surface receptor CD21, it gives access to the Epstein-Barr virus to enter inside. First of all, let us see how this Epstein-Barr virus gains entry. Epstein-Barr virus, it is transmitted via saliva through kissing. Hence, it is also called a kissing disease. So, from saliva, it reaches the oropharyngeal. It reaches the oropharyngeal epithelial cells in the mouth, and they get infected, carried via these epithelial cells to the nearby lymphoid tissue, that is tonsils. Tonsils contain lymphoid tissue, means it has the lymphoid follicles with B cells. This is how the first B cells get infected. These infected B cells are carried via the afferent lymphatics to the cervical lymph nodes. To the nearby lymph nodes will be cervical lymph nodes and other regional lymph nodes. Finally, reach thoracic duct, thoracic duct, and finally drain into left subclavian vein. This is how it enters the circulation, and from the circulation again carried to distant lymph nodes like inguinal lymph nodes. So it stays in circulation. This is the entry. This is how the B cells get infected by the Epstein-Barr virus. So once it gains access inside this B cell, the Epstein-Barr virus, it remains silent for some time, and it takes its own time to decide which pathway it has to choose. Like after we give exams, we take some time. Okay, depending on my marks, which branch I shall take. So it takes its own time to choose its path. This is called latency 2 period. That is, it is a silent period. Latency 2 program. It adopts a latency 2 program wherein it will decide which pathway it has to choose to survive, to proliferate, and to escape the immune system and flourish as a tumor. So it adopts this latency 2 program during which it expresses EBNA1. It will express EBNA1, that is Epstein-Barr nuclear antigen. This is the Epstein-Barr nuclear antigen, and LMP1, that is the latent membrane protein 1, latent membrane protein 1, and LMP2A, that is the latent membrane protein 2A, and EBER, that is the Epstein-Barr virus encoded RNAs, and finally VIL-10, that is the viral interleukin 10. This is the viral interleukin 10. These are produced by this virus. The role of EBNA1 here is the expressed EBNA1. Its role is to maintain the Epstein-Barr virus episome. Episome means the viral genome that has not integrated with the host genome. It has not lost its identity. After the access into the cell, this Epstein-Barr virus, it will integrate into this host DNA. But some part of it, it retains its own identity. That is called an episome. So this episome is maintained by Epstein-Barr virus nuclear antigen, which is present in the nucleus itself, which with each cell cycle, the episome also replicates, and it ensures the virus is persistent in the RS cell. So the episome will ensure viral persistence in the RS cell, which is brought about by this EBNA1. The EBNA1 is present in the nucleus. Its role is to maintain this episome. Coming to the LMP1, that is latent membrane protein 1, it is expressed onto the surface, LMP1. This LMP1, it will mimic the CD40 receptor. It mimics means it acts as if it is a CD40 receptor. This CD40 receptor is a normal cell surface receptor of a normal B cell. First, let's see what is the normal function of CD40. This CD40 present normally in inactive state. That means when no signal has touched the CD40, this NF-kappa B, in the cytoplasm there is a transcription factor. It is called NF-kappa B. NF means nuclear factor. Kappa is the kappa light chains of the antibody of B cells. This is the full form of NF-kappa B. It is in bound state. It is in bound state to the inhibitors. I-kappa B are the inhibitors. These are the inhibitors of the NF-kappa B. In inactive state, these are CD40. When it is inactive, does not receive any signal. This NF-kappa B is bound to its inhibitors in an inactive state in the cytoplasm. Whenever there is a ligand, CD40 ligand, it binds to the receptor, it gets activated. That means a signal has been received and it transmits the signal inside the cell. Now, this inactive NF-kappa B has received this signal and it also gets excited, that is, it gets activated. Out of excitement, it will leave this inhibitor, it will shed out the inhibitor and gets free. So once it is free, when you're bound to someone, you're inactive. Once you get free, the nuclear factor NF-kappa B, when it's free, it becomes active. It gets translocated. That means it gets transported to the nucleus. It gets transported to the nucleus, and it will cause transcription of certain genes. Like it will cause gene expression that are responsible for B cell proliferation. It leads to uncontrolled B cell proliferation. Sorry, no, in case of normal NF-kappa B pathway, as long as it is stimulated, it will cause B cell proliferation. Whereas in malignant RS cell, in the malignant B cell, this LMP1, it will mimic this CD40 even with the absence of CD40 ligand. Even when the ligand is absent, the LMP1 is constantly active. It is called constitutive activation. It is constitutively active. So it will constantly stimulate this NF-kappa B. So this constantly activated NF-kappa B, it will get transported to the nucleus. It will cause again the same gene expression. Since the signals are uncontrolled, this constantly active, it will lead to uncontrolled B cell proliferation. Whenever any cell cycle or the cell division becomes uncontrolled, it will lead to tumor. Here, the uncontrolled B cell proliferation will cause Hodgkin's lymphoma. This is how the LMP1 works. Coming to the second thing, that is the LMP2A, which is also LMP2A, which is also expressed on the cell surface here, LMP2A, it will mimic the B cell receptors. So again, coming to the normal, the B cell receptor present on the cell surface of the normal B cell, it is a surface immunoglobulin. It is a surface it is a surface immunoglobulin present on the normal B cell. Whenever there is an antigen, specific antigen binding to the B cell receptor, it will send signal to the nucleus and cause this production of anti-apoptotic genes. Anti-apoptosis means again the B cell will not undergo any apoptosis, it will survive. And there is pro-proliferative genes. It will pro-proliferative means active cell division. So it will proliferate. B cells they divide. Cell cycle, it favors the cell cycle. This is how the B cell receptor works. It whenever it receives signal from the binding of specific antigen, it will translocate the signal to the nucleus, cause production of anti-apoptotic genes that will like suppress the apoptosis of B cells and produce pro-proliferative. That means it will favor the cell division. This is the function of B cell receptor with which on activation, that means it gets activated only when there is a specific antigen binding. Whereas in cases of this tumorous B cell, this LMP2A is expressed, which mimics this B cell receptor. Mimics means it will be active even without the presence or even without this antigen binding. There's no need of antigen, it is constitutively active and it sends signals to the nucleus, cause the same anti-apoptotic genes and pro-proliferative genes. Like since it is like constantly active, it will cause uncontrolled B cell proliferation that will cause Hodgkin's lymphoma. And there is another thing called JAK and STAT. So the normal JAK, it is attached to the cell surface. It is attached This is a cell surface receptor tyrosine kinase, the cytoplasmic domain. It is called JAK. Whenever this receptor gets activated by any signals like growth factors or any other survival signals, the JAK will get activated and it will aggregate. It will cause aggregation of STAT molecules. STAT molecules are present in the cytoplasm. The full form of STAT is signal transducer and activator of transcription. As the name suggests, one signal transducer means it will transport the signal received by this JAK and activate the transcription in the nucleus. So the STAT molecules get active, they aggregate, get transported to the nucleus, again cause gene expression for B cell proliferation. So in case of this infected B cell, this JAK is constantly active. It either undergoes amplification. It undergoes amplification, cause constant aggregation of STAT that are translocated to the nucleus, cause gene expression for B cell proliferation, ultimately causing Hodgkin lymphoma. And there are certain Epstein-Barr, this is EBER, the Epstein-Barr virus encoded RNAs. So these are the RNA molecules that are encoded by the virus. What do? They will block the apoptosis. This EBER, they will bind to protein kinase receptor and they block the apoptosis. They block apoptosis. When apoptosis does not occur, that is, the induced cell death does not occur, this infected B cell will survive. It will survive. This infected B cell will survive. And also, it will block this interferon pathway. Interferon pathway, it is required for macrophage recruitment and activation. Macrophage will cause this microbial killing. It will cause phagocytosis and microbial killing. So when there are no macrophages, there will be no phagocytosis, no killing. This is how the virus will survive. This will also cause survival of the infected B cells when there are no macrophages. This is how it will cause immune evasion. That means evasion means escape. It will escape the immune system and the RS cell will grow. Also, this encoded RNAs, they will induce production of interleukin 10. Interleukin 10 is anti-inflammatory and insulin-like growth factor, which will contribute to this escape of immune checkpoint and RS cell growth. And the virus, it will secrete the viral interleukin 10. It will secrete this viral interleukin 10, which is produced as a vacuole in the cytoplasm. This viral interleukin 10 will suppress the normal Th1 response. Th1 cells are the CD4. These are the CD4 T helper lymphocytes. T helper lymphocytes. The normal function of the Th1 cells are to produce interferon gamma, interleukin 2, TNF beta, tumor necrosis factor beta. So the interferon gamma, so macrophages. So it will activate the macrophage, kill the intracellular microbe. This is a normal function. Interleukin 2, 2 means for T. 2 will recruit and activate the T cells and also other cytotoxic cell like the natural killer cell proliferate. All this together, they will cause killing of the infected cells. They will eliminate the pathogens. Tumor necrosis factor beta, TNF beta. It will secrete pro-inflammatory cytokines and cause a cytotoxic response. Cytotoxic means the infected cell. Cytotoxic. It was killed by this T lymphocytes. So this Th1 cells, these are the normal function of the Th cell, all good functions of the Th1 cells. These are suppressed. It is suppressed by this viral interleukin. So viral interleukin 10, it is produced by the virus in the cytoplasm. This viral interleukin will suppress all the good actions of the Th1 cells so that it can survive. So this is in brief about the pathogenesis. Also, the LMP1 here, it has additional function to create a tumor microenvironment. It creates a tumor microenvironment. It will support itself by creating a friendly atmosphere around itself. So it has to thrive, it has to like survive. It will create an environment in such a way that it can flourish. and will create its own friendly environment. By secreting, the LMP1 will secrete interleukin 5 and 13. The interleukin 5 is well known for eosinophils, and 13 also it will cause Th2 differentiation. So it will attract eosinophils and Th2, that is the CD4 lymphocytes, get differentiated and get attracted. Although they are in an inactive state, they are just supporting characters. And TGF beta here, they will promote fibrosis. That is around the tumor cells, like a cushioning effect. All the fibrous bands, collagen bands are produced around this tumor cells. And CCL5, that is, it is also called rantis, well known for chemotaxis of CD4 lymphocytes. It will attract CD4 lymphocytes, which do not, when they are in inactive state, they do not cause any cytolysis. They are just supporting characters. And this GM-CSF, that is the granulocyte monocyte colony stimulating factors and the interleukin 6, they will recruit and cause macrophage recruitment. They will cause macrophage recruitment and also plasma cells. But these are present in inactive state. They are inactive state because of suppression by this viral interleukin 10, and these cells are just present like a cushion atmosphere around the RS cell. This will form the typical mixed inflammatory background. They'll form a typical mixed inflammatory background. Like there is one RS cell here, this is one RS cell. Supporting structures, many inflammatory background cells are present. It's like cushioning effect. Almost the bulk of the tumor formed by mixed inflammatory cell. 95% of the bulk of the tumor is formed by this mixed inflammatory cell. Only less than 5% of the tumor bulk is formed by this RS cell. So this is in brief about the role of Epstein-Barr virus in causing the Hodgkin's lymphoma. In other causes like non-infectious causes like genetic and molecular pathways, there is mutation associated with this NF-kappa B, where the NF-kappa B gets constantly active, and JAK-STAT pathway, PD, L1 and L2 overexpression, these are present on the surface of this B cell, and BCL2 expression. So NF-kappa B, so due to certain mutations, NF-kappa B activation, it is brought about by the Epstein-Barr virus LMP1, as we have studied in the role of Epstein-Barr virus. Other than that, there can be mutation of REL gene. So on chromosome 2, for example, there is a chromosome 2. There are two copies of the chromosome. There are two sets of chromosomes. And if at all there are like multiple sets, multiple gain copies of this chromosome 2 will increase. The chromosome 2 harbors REL gene. The REL gene gets amplified. It gets amplified. The function of REL gene is to stimulate NF-kappa B. NF-kappa B means it will get translocated to nucleus, cause B cell proliferation. Here it is uncontrolled B cell proliferation, ultimately causing Hodgkin's lymphoma. This is the role of REL gene present on chromosome 2. Also, there can be mutation of inhibitors of NF-kappa B. I-kappa B is bound. It will bind to NF-kappa B and cause its inactivation. If there is a mutation of this NF-kappa B, this mutation of inhibitors, the NF-kappa B will be free. Always it is in free form and it gets translocated to nucleus and cause a gene expression. So when there is no control, when there are no inhibitors, when there is a no check, the mutation of inhibitors will cause loss of this check. The nuclear factors will get translocated to nucleus and cause B cell proliferation. This is about the NF-kappa B activation. Coming to the JAK-STAT. So this Reed-Sternberg cell, it secretes interleukin 13, which has autocrine function. That means it acts on itself and cause STAT6 activation. So STAT6 are present in the cytoplasm of B cell. The STAT molecules are present in the cytoplasm of the B cell. On activation, they get aggregated, translocated to nucleus and express genes for B cell proliferation. So this is how the Sternberg cell, by producing interleukin 13, will constantly activate STAT6 responsible for proliferation. This is about the mutational JAK-STAT pathway. Coming to the PD-L1 and L2 overexpression. So PD-L1, L2 present on the B cell surface, PD-L1 or PD-L2 present on the cell surface, whenever there is an amplification of this chromosome 9p, this L1, L2, they are encoded by chromosome 9p24, or remember 9. Whenever this gene gets amplified, there will be overexpression of PD, L1 and L2. PD, L1, L2, what do they cause is they inhibit the T cell mediated killing. They inhibit, their role is to just inhibit the T cells so that the RS cell will escape the immune checkpoint. They'll escape the immune scrutiny. That's it. And also there can be certain mutations that will lead to BCL2 expression. BCL2 is anti-apoptotic. BCL2 is anti-apoptotic. So it will prevent apoptosis and cause the survival of the mutated B cell. These are the few pathways, genetic and the molecular pathways, and other being the immune evasion. Here, TREX means T regulatory cells. TREX means T regulatory cells. What do they regulate is they regulate the cytotoxic T cells. They suppress the CD8 cytotoxic T cells. Therefore, the RS cell, that is the neoplastic B cell, they are shielded. That means they are protected from the immune attack. They are protected from the immune attack by suppressing the CD8 T cells. CD8 T cells, they are suppressed by TREGs. TREG means T regulatory cells. This is how the T regulatory cells will help this notorious cancerous B cell, that is the RS cells, to escape from the immune scrutiny or the immune attack. Also, this is a supportive tumor microenvironment. It is brought about by this LMP1 that will secrete all the interleukin 5, 13, CCL5 as we have studied, and here TGF beta and GM-CSF. This supportive microenvironment that creates a mixed inflammatory background, like the supporting microenvironment is brought about by LMP1 that secrete all these factors. These are the other factors. So these are all the factors responsible for causation of Hodgkin's lymphoma. So let's summarize. The Epstein-Barr virus infected B cells through this LMP1, which mimic that CD40. It will constantly activate NF-kappa B, LMP2A, which mimics BCR, constantly activate the gene expression. JAK2 amplification will always constantly activate STAT. All these three together cause nuclear gene expression for B cell proliferation. B cell proliferation. Here, the Epstein-Barr virus encoded RNA. RNAs will cause production. It will it will inhibit apoptosis and cause immune escape. This is how it helps the survival of the infected B cells. And the viral interleukin 10 also causes immune suppression by suppressing the Th1 cell response. It will suppress this and cause immune suppression. Genetics by this mutation of NF-kappa B, JAK-STAT, and this overexpression of PD, L1, L2 brought about by chromosome 9, and BCL2 expression, that is the anti-apoptotic, and there's a REL gene amplification because of gain of multiple copy gains of chromosome 2. And the tumor microenvironment we have studied, which is brought about by this LMP1, which secretes certain cytokines responsible for the mixed inflammatory background. This is about the summary of this brief summary of pathogenesis of a Hodgkin's lymphoma. Coming to the classification. Now let us classify the Hodgkin's lymphoma. So Hodgkin's lymphoma, it is classified under two headings, classical and non-classical. The classical has four entities. These are the four entities of the classical. Under non-classical, we have only one. Thank God we have only one under the non-classical. The classical, it is associated with Epstein-Barr virus infection, and the B lymphocytes here they express CD15, CD30, and PAX5. These show IHC positive for CD15, CD30, PAX5. PAX5 it is a marker of B cell. It is required for B cell. PAX5 gene. PAX5 gene responsible for B cell development. Hence PAX5 is positive in classical. Non-classical, it is not associated with Epstein-Barr virus and the infected no, and this RS cells here they express CD20, CD45 epithelial membrane antigen, that is EMA positive, and BCL6 positive. These four markers are positive in non-classical. So let us get familiarized with the entities, with the terms in under this classification. The first is nodular sclerosis, mixed inflammatory, lymphocyte-rich, and lymphocyte-depleted. Under the non-classical, we have nodular lymphocyte-predominant Hodgkin lymphoma, NLPHL, nodular lymphocyte-predominant Hodgkin lymphoma. Let's go one by one. The nodular sclerosis, it is the most common overall worldwide. Worldwide, it is the most common. Also, it is associated with formation of collagen bands, and it has the best prognosis. It has the best prognosis among classical Hodgkin's lymphoma. The mixed inflammatory, it is most common in India. As the name suggests, the background has mixed inflammatory cells like lymphocytes, plasma cells, eosinophils. So mixed inflammatory. And the lymphocyte rich, the background has the dense lymphocytic infiltration. This will predominate. And the lymphocyte depleted, that means the absence or the scarcity of lymphocytes. The inflammatory background, the background of supporting microenvironment is scarce, and it is most commonly associated with immunodeficiency syndromes like HIV, Epstein-Barr, and all this immunocompromised states. The lymphocyte depleted pattern is seen. This non-classical has nodular lymphocyte predominant Hodgkin's lymphoma. This has the best prognosis. This has the best prognosis overall among the all Hodgkin's lymphoma. So there's a difference here. Among the classical, the nodular sclerosis has the best prognosis. When it is asked among all Hodgkin's lymphoma, it is the non-classical, the nodular lymphocyte predominant. This nodular lymphocyte predominant, it has the best prognosis overall. But when it is asked among the classical, the nodular sclerosis will have the best prognosis. And we can even further classify based on this RS cells. So first let us see the variant of RS cells. RS cells are the disease defining cells. The Reed-Sternberg cell is the disease defining cell. It is the disease defining cell. It has certain variants that we'll look into now. The first image, it is of a classical RS cell. It is of a classical RS cell. Here we see the center cell, which is large atypical lymphocyte. It has two nuclei. There are two nuclei which are mirror images of one another. And inside the nuclei, we see these eosinophilic inclusions. These inclusions are present. So like this. This is the outer, this is the cell. There are two nuclei and there are eosinophilic inclusions. It gives an appearance of an owl's eye. Like these two are the nuclei with eosinophilic inclusions. It appears like an owl's eye, mirror images of one another. This is called a classical Reed-Sternberg cell. And the size of this cell is, the Reed-Sternberg cell, it ranges 45 microns in size, and the size of this eosinophilic inclusion is 7 microns. And in the background, you can see this is the RS cell. The background of the RS cell shows mixed inflammatory cells. These are the lymphocytes. All these are the lymphocytes. Here, there's a plasma cell with eccentric nucleus. Plasma cell which has an eccentric nucleus. For example, this is a plasma cell. It has this eccentric nucleus. Lymphocyte will have like center nucleus. Lymphocyte will have center nucleus like this. And there is also eosinophils like orangish cytoplasm. Orangeophilic cytoplasm is characteristic of eosinophils. So there is presence of lymphocytes, plasma cells, eosinophils with presence of classical RS cell. It is seen in mixed inflammatory variant, mixed cellularity, Hodgkin's lymphoma. Coming to the second image, here also there are like RS cells are present. The classical RS cells are present here, and the background also shows mixed inflammatory. The difference here is, for example, these are the RS cells. These are the RS cells. There are like dense, there will be fibrous bands in between these cells, fibrous bands around the cells, and this mixed inflammatory background. All the inflammatory background will be present. And here, this light pinkish are the fibrous bands. This light pinkish are the fibrous bands. These are the cells. These are the inflammatory background containing the lymphocytes. So this is these are the fibrous bands. These are the cells, RS cells. These are the RS cells. This is the inflammatory background here with all the lymphocytes. These are the lymphocytes. And there is a certain halo around each of this RS cell. RS cell here, and there's a clear halo around it. This clear zone of halo. This clear halo present around the cell. This halo is because of formalin. Whenever a histopathologist sample this lymph node after its excision, the lymph node once it's excised, it will send to histopath in a formalin container. This container has this formalin where the lymph node is sent. Because of this formalin fixation, during tissue processing also it is fixed in formalin. The formalin will cause retraction of this collagen bands. It will cause the retraction of collagen bands that is responsible for this halo around the cells that will cause this gap around the cells. The gaps around the cells, are called lacuna. Lacuna in literal English means gap. Lacuna means a gap or a missing point. Therefore, these RS cells are called lacunar RS cells, which is found in nodular, nodular, nodular sclerosis variant of Hodgkin's lymphoma. So the nodular sclerosis variant has lots of collagen and RS cells. So let's summarize. This is a nodular sclerosis variant. It is characterized by lots of collagen bundles that will retract because of formalin, that will lead to formation of lacuna around the RS cells that will cause this lacunar RS cells. This is about the nodular sclerosis. Coming to this third picture, here the RS cells are present but they contain a single nucleus. That is, there is a single nucleus with an eosinophilic inclusion. So the single nucleus is called mononuclear RS cell. Mono means single, that is one. Nuclear means single nucleus, and reads Sternberg cell. This is found in lymphocyte-rich variant. All the rich tycoons, rich industrialists, or the rich businessmen, they imposed monopoly over the industrialization. We can remember they rule singly. Singly means one, ek niranjan kind. So this mononuclear RS cell found in lymphocyte-rich variant. This is here the RS cells are present, but it has a dense pycnotic nucleus. The nucleus is dense and pycnotic, and the membrane, cytoplasmic membranes are irregular. So these are called mummified. These are called the mummified RS cell. Mummy means a Egypt mummy. It's a dead body. Hence these cells are like dead degenerating RS cells. These indicate dead degenerating RS cell. Dead degenerating RS cells are called mummified RS cells. These are found in lymphocyte-depleted variant. Depleted means there's scarcity or there's dead degenerating. You can remember depleted seen in dead degenerating. Hence, mummified RS cell found in lymphocyte-depleted, most commonly associated with immunodeficiency syndromes. This is about this classical RS cell found in mixed cellularity, nodular sclerosis found characterized by presence of lacunar RS cells, mononuclear RS cell found in lymphocyte-rich, mummified dead seen in lymphocyte-depleted. This fifth image, it shows you RS cell, but it has a popcorn configuration, like with irregular membrane. The cell has irregular membrane like a popcorn. See, popcorn outer surface is very irregular, like cloudy. This so these are called typical popcorn RS cells. These are called the popcorn cells, which are found in the non-classical, that is, the nodular lymphocyte predominant Hodgkin's lymphoma has this popcorn cells. Popcorn cells, this is a popular name. It is also called LNH cells. So let us now again come back to the classification. In the classification, nodular has this lacunar. You can remember like a rhyme, lacunar, nodular, nodular, lacunar. Mixed has this classical. It has classical RS cell. Lymphocyte rich, rich people monopoly. So mononuclear RS cell. Lymphocyte depleted, depleted means dead, degenerating mummy. So mummified. So mummified RS cell. The non-classical will have a popcorn. It will have this popcorn RS cell. So nodular lymphocyte predominant Hodgkin's lymphoma has this popcorn. This is doing with this classification along with the morphology, the variants of RS cells, which are the disease-defining cells. Done with this, coming to the clinical features of Hodgkin's lymphoma. So the most common presentation being the lymphadenopathy, that is the painless enlargement of the lymph nodes. The most common lymph nodes affected are cervical, axillary, inguinal lymph nodes, also supraclavicular, mediastinal lymph nodes are involved. And the most common site, there can be extranodal involvement, which is usually rare in Hodgkin's lymphoma. But if it occurs, extranodal means outside the lymph node, any other organ, lymphoid tissue. The most common site being the stomach. The stomach wall has lymphoid tissue. That is the most common site of the extranodal Hodgkin lymphoma. In cases of HIV, the most common site of extranodal is the brain. The brain is the most common site of extranodal Hodgkin's lymphoma in HIV patient. In normal, it is stomach. And after this painless lymphadenopathy, other symptoms are the mediastinal mass, especially associated with nodular sclerosis. This I have forgot to tell in the classification. The nodular sclerosis associated with mediastinal mass, and the patients present with B symptoms. Most often they present with B symptoms. These symptoms include three, that is fever, weight loss, unintentional weight loss, and night sweats. Fever, weight loss are because of certain cytokines like interleukin 1 and tumor necrosis factor alpha. These both contribute to fever and weight loss. Night sweats are because of interleukin 6. And there can be pruritus or skin changes because we have discussed that this LMP1 can produce interleukin 5, which cause eosinophil recruitment. Eosinophils make up the inflammatory background. Whenever these eosinophils degranulate and it releases histamine, the histamines cause cutaneous nerve endings stimulation. cause the cutaneous nerve ending stimulation. Therefore, there is pruritus, itching, or the skin changes are because of interleukin 5, the eosinophils. And there's no underlying reason known. There is alcohol induced pain in the lymph nodes. Whenever the patient consumes alcohol, the pain increases in the lymph nodes. People usually drink alcohol for any happiness and also to forget the pain, but sadly in Hodgkin's lymphoma, the patient feels the pain on drinking alcohol. The reason is unknown, and there can be splenomegaly and hepatomegaly in advanced cases when these neoplastic B cells reach spleen and liver, and whenever they infiltrate the bone marrow infiltration by this neoplastic cells will replace the normal myeloid precursors. It will cause pancytopenia. That will cause anemia, leukopenia, and thrombocytopenia and related manifestations of anemia. Anemia will cause fatigue, weakness. Leukopenia will cause recurrent infections. Thrombocytopenia will cause bleeding tendencies. These are the few clinical features of Hodgkin's lymphoma. That is, most common presentation will be the painless lymphadenopathy, painless enlargement of the lymph nodes. The most common sites are cervical, axillary, inguinal, supraclavicular, mediastinum also. So, and there's a staging for this Hodgkin's lymphoma, and the name of the staging is Ann Arbor staging. Ann Arbor staging is used to stage this Hodgkin lymphoma. And the staging includes four. There are four stages, and each has A and B. A is for when there's no B symptoms. No B symptoms. B symptoms are absent means A. B means B symptoms are present. B symptoms present. B है तो B. When B is present, it is comes under B stage. A means absent B symptoms. So let us see the stages. A means there's single lymph node region affected, either like cervical group or the axillary group. Either one single lymph node region will be affected in one first stage. The second stage involves two or more lymph nodes on the same side of diaphragm. Same side of diaphragm means, for example, this is a diaphragm which is a muscular sheath. This is the thoracic cavity. This is the abdominal cavity, and on the same side the lymph nodes, two or more lymph nodes will get affected. Either hilar lymph nodes or the axillary group, they get affected on either on one side, either thoracic. If it has to involve the abdominal, it can involve either the pelvic, para-aortic, inguinal lymph nodes can get affected. Either it should be like either thoracic or it should be either abdomen. Either one on one side, either of the side, or either on this side or that side. Then it is stage 2. Stage 3 means lymph node on both sides positive. Both sides will be positive in stage 3. Stage 4 means distant metastasis, distant, like extranodal sites also, to the spreading to the stomach wall, the brain, bone marrow, liver, spleen. So distant site involvement means stage 4. And each stage has A, B present with which depends on the presence or the absence of B symptoms. A means absence of B symptoms. B means B symptoms are present. What are the B symptoms? Fever, weight loss, night sweats. These are the B symptoms. This is about the Ann Arbor staging of Hodgkin's lymphoma. Coming to the investigations, what are investigations we do in Hodgkin's lymphoma? When we do a CBC, we find anemia mostly, which is normocytic, normochromic, and there is leukocytosis initially, that is increase in WBCs with eosinophilia. Eosinophilia is because of interleukin 5, therefore it will contribute to mixed inflammatory cell infiltrate. And whenever the bone marrow is involved, bone marrow infiltration, then it can lead to leukopenia. And there is thrombocytopenia. When you do an ESR is raised. In any infectious or the inflammatory or immune causes, the ESR rises. So here also the ESR is raised. LDH is raised, which is suggestive of high tumor turnover. High tumor turnover means highly proliferative. Highly proliferative. If it's highly proliferative, then the LDH, lactate dehydrogenase, will be raised. And There is increase in this acute phase reactants like serum ferritin C reactive protein. Ferritin C reactive protein are also raised, which are the acute phase reactants. Whenever there is a lymph node biopsy done, the histopathology will show this disease-defining cell, that is the Reed Sternberg cell, in an inflammatory background. And when you perform an immunohistochemistry, the classical ones will show positive for CD15, 13, PAX5, as we have discussed in the classification, and the non-classical ones, that is the nodular lymphocyte predominant Hodgkin lymphoma, will show positivity for CD20, CD45, and BCL6. Coming to the imaging, the chest X-ray, it might show mediastinal masses. This is especially prominent in nodular sclerosis variant. Nodular sclerosis variant. Also, the SET and PET, CT and the PET CT, they show nodal and extranodal diseases. The bone marrow biopsy, aspiration and biopsy, it is done in stage 4, that is advanced diseases. Stage 4, when there is extra like distant metastasis, when the bone marrow gets involved, bone marrow biopsy is done in stage 4, it may show the bone marrow itself, it may show Reed Sternberg cells, or it can be heavily fibrosed because of this RS cells infiltration, which stimulate TGF beta. TGF beta will cause extensive fibrosis. And coming to the viral testing serology, there can be more commonly associated with HIV, Epstein-Barr, and the HIV virus. More commonly associated with this lymphocyte depleted, and the mixed cellularity variants. This is about the investigations of Hodgkin's lymphoma. Coming, let us first differentiate what is Hodgkin's and what is non-Hodgkin's. Hodgkin's will comprise the 10% of all lymphomas, non-Hodgkin's the remaining 90%. And the age group affected, as we have discussed, Hodgkin's show a bimodal distribution. Bimodal distribution, first peak between 15 to 35 years, second peak in elderly above 55 years. This non-Hodgkin's always it is seen in elderly above 55 years. There are no two peaks, there is a single age distribution. The most common lymph nodes affected in Hodgkin's lymphoma are the cervical group, axillary group, and the inguinal group of lymph nodes are affected. Here, non-Hodgkin's, it is deep-seated like Waldeus ring, and the mesenteric lymph nodes. Mesenteric lymph nodes are affected in non-Hodgkin's, and the extranodal involvement in Hodgkin's lymphoma, it is rare. And also we have discussed, even if it is rare, if it occurs, the most common site is the stomach in normal individuals. In HIV, it is what? It is the brain. It is the brain. And the extranodal involvement in non-Hodgkin's is very much likely in non-Hodgkin's. And the spread in Hodgkin's lymphoma, it is characteristic contiguous spread. What is contiguous means? Continuous. For example, it affects a cervical group and there is a chain of cervical groups present. If this cervical lymph node is affected, it immediately affects the adjacent. It again immediately affects its adjacent. It again immediately affects. So like a chain, it affects all the lymph nodes in the line. So like a chain reaction, everything, all the lymph nodes in that line will be affected. This is a contiguous spread seen in Hodgkin's lymphoma. Whereas in non-Hodgkin's, it is non-contiguous. Non-Hodgkin, non-contiguous. That is, it is not continuous. For example, you take this set of lymph nodes. If, for example, this is affected, it will skip this second, third will be skipped, it will affect the fourth, again fifth will be skipped, sixth will be affected. So there is a non-continuous, there are skipped, it shows a skip pattern. So it is a non-contiguous spread seen in non-Hodgkin lymphoma. This is a brief differences between Hodgkin and non-Hodgkin's lymphoma, which is useful for your exams and also for Viva and practicals. So this is all in detail about the Hodgkin's lymphoma. If you like this video, please like, share, and subscribe to my channel. Thank you everyone.